So I'll just do a roll call. So Dr. Bazithra, are you here?
Hi, yes, I'm here.
Okay, great. Welcome. All right. It's nice to see people coming back every week. So it's good to see you. Helen, are you here?
Yes, yes, I'm here.
Okay, great. Sorry about last week. Or like last session at least. Riddy, are you here?
Yes,
Okay, am I saying that right?
yeah.
Okay, good. Well, welcome. It's good to see you again. All right, and Sayeda. Sayeda? Oh, I think there's a chat. Hi, sure, you're here. Do you have your audio this week? Ah, okay. Generally speaking, I know last time we were cool with chat just because you're a veteran and but ideally we would, you know, going forward we'll put people in waiting rooms and have the audio be kind of a requirement. It's a small group today, so it doesn't really matter. But like to do that. Just it's one of the things that compensates me as the video goes a little bit better than having just chat and me talking to myself. Because when people are watching, they really prefer that the video's on and they can see everybody answering, and it just makes it more compelling to watch, as well as makes it more kind of fair to the people who are answering. So sorry to open up just giving you that assessment, but I appreciate you being here anyway. So it's good to see you again. Um, what else did you see? So I'm gonna open up with a lecture if you guys don't mind. This is something that I do a lot. I don't know if people appreciate it. I'm gonna read some of the feedback going forward, but it's just like a um, something that I do to really quick reference answers to questions. And this is just a question that comes up all the time. Um, and I just feel like it's so easy to kind of have this U-world diagram and not apply fundamental kind of like no pun intended, but like a sniff test to identify like, is this the right answer even though my memory of this material is kind of faint, or at least unlike polished. And so um, let's go through something that you'll like see over and over and over again. This is something that you'll see on step 1, step 2, step 3, over and over and over again, and you may not feel like super comfortable with this material until you have a like pictographic representation of the information in your head. So what am I talking about? So vulvovaginosis, right? So like it's basically a vaginal infection of the vulva, uh, infection of the vulva or the vagina. So they're going to be causes of this. There's like 3 major causes of this. Do you guys know what the causes of vulvovaginosis are in terms of I'll give you one of them. One of them is bacterial vaginosis. Do you know what the other 2 are? So there's Candida albicans. Have you guys heard of that? Candidiasis. It's also called thrush. So you have bacterial vaginitis, and then you have Candida albicans. So do you guys know what the middle term is? What's the third one? I'm just I'm gonna call on people, but you don't have to answer, just because I don't want to sit here and like, because I think it's super useful to get to get into it and be interactive. So I like that as a student. So I'm just gonna be Helen. Do you know what the other diagnosis you can have for vulvovaginosis is?
Gardnerella,
Sorry.
Gardnerella bacteria.
So that's a
Fungal.
great answer. Gardnerella would cause bacterial vaginitis. So Gardnerella is to bacterial vaginitis like there are other causes, but the most common cause is Gardnerella, which and the truth is the only one you'll need to know for the exam is Gardnerella, and that you'll want to associate with bacterial vaginitis because they're really, for all intents and purposes, that's the organism that will cause that. So, what causes candidiasis? Candida albicans, right?
Yeah.
All right, all right. So I'll be back. I'll just like rotate. So Dr. Bazithra, what is true about like Candida? Like what type of infection is that? What type of organism is that?
Is it yeast? Yeast.
Yeah.
Fungal infection.
So is that an animal or a plant?
It's a plant.
It's a so yeast is not a plant. It's like so is it a bacteria or a fungus?
It's fungus.
Fungus, exactly. Some of these classifications, like I know you know the answer, and I'm asking you to use biological terms in English all of a sudden, and I can imagine that it on occasion you're like, okay, yeah, well, you know, I know that fungus isn't a plant, and I'm putting you on the spot and poking at something that isn't really fair, but yeah, this is Candida albicans is a fungus. So one of the things that what are some of the what is like the third? Do you know, Dr. Bazithra, like what is another cause of bacterial vaginosis that occurs like really commonly? There's 3 of them. This is a hard question.
I know. Yeah, I know of yeast and the fungal infection and bacterial.
Yeah. Fungal, bacterial, and then there is... So those are 3 categories, right? That's a good point. Like, here we have bacterial, here we have fungal, and then I would say that there's probably... Like, if it's not a bacteria and it's not a fungus, what might it be?
Not sure on the third one.
Oh, so could it be like an insect?
Viral.
Yeah, you could have exactly. So that's the sort of thing that I'm trying to get. I'm trying to get you. So like, this is the sort of thing where if I didn't know the answer on an exam, I would start listing things that just like make sense to me. Like just start listing things you know in your mind for a second. You only have 90 seconds, but like if you really know that you don't know the answer, start like thinking of things that you can use, like just assets that may or may not, be helpful. But so viral is a cause of many types of infection, but it isn't the cause of this specific infection. So if we can rule out bacterial, viral, and fungal, what is another category? Just in your
I'm not too sure.
just in your daily life, if you met someone and they said, I have an infection, but it's not bacterial, it's not viral, it's not fungal. I would think about... You what?
Parasite.
Exactly. So no, this is good. Because if there's a foggy part, if you're like thinking like, okay, it takes me a while to think of those categories, awesome, because that's going to help you in so many questions. Like whatever score you have now just improved because you have this at the tip of your tongue for future questions. So parasites can be like insects, and they can be like worms, like nematodes, right? So I'm just gonna write worms because I'm being super like I'm writing this like I was 5 years old. Like not that this is 5-year-old information, but like I'm writing this like I want to remember this in 2 seconds. So I'm writing the simplest diagram I can. So I'll stop picking on Dr. Bazithroff. That's absolutely right. That's parasite. So bacterial, parasite, fungal. So Reedy, are you familiar with maybe another cause of
Protozoal, Trichomonas vaginalis.
exactly. So that's a parasite, right? That's caused by is that a worm or an insect?
It's protozoal disease.
It's protozoa, right? It's not either. So that's a great answer. Okay. And so so what I do is I remember this with like BTC. Okay? So bacterial vaginitis, trichomonas, right? And then you have candidiasis. So this is kind of a chart, but I don't write the charts in my mind, okay? I'm just these are columns and they go down. So everything below B applies to bacterial vaginitis. Everything below T applies to trichomonas, and every thing that applies to candidiasis is going to be below C. So so we'll keep going. So Reedy, which two categories, which categories cause an odor?
Sorry, I can get your question. Which category?
So odor meaning like a smell.
Okay. Oh, odor. Okay. Sorry.
Yeah, sorry.
Fishy smell.
Yeah.
It's in the bacterial.
Yep.
Trichomonas is malodorous, and Candida is cheese-like or white card condition.
Right. So which categories are going to smell?
Oh, bacterial.
Bacteria.
Bacterial vaginosis.
And there's one more.
Yes.
There's another one that smells.
Trichomonas.
Chlamydia?
Trichomona. Yeah. So Candida doesn't. And that's one of those things that I think I got wrong 12 times. Because it's one of those things where I always assumed it was just B. But what I do is I draw a picture that represents like smell, right? So this is like smell representation drawing. And you know, when you're making an image that's supposed to be memorable, I like to make things that I can't. They're just so funky and weird that I'm going to remember them. So the more weird and out there they are, the better, because I want to remember this forever. I'm going to have patients who come in and they have this problem, and there's going to be this problem on the exam over and over again. So this represents B and T have a odor. And like you said, a fish-like odor is often associated with B. But there will be, you can have a fish-like odor in Trichomonas. So that's one thing to keep in mind. So the next one is, which of these will cause inflammation?
Trichomonas.
Right. So I think that was that Reedy again?
Yeah.
All right, you're doing pretty well. I'm gonna pick on someone else for a little bit here. Abad, are you here? Can you hear me? Is it Abad? Okay, Abad, you're very welcome. I hope you can hear me. I'm going to put you in the waiting room just for a moment. When your audio is coming back and working, just join us again. There's no problem. What I do is I like to separate people into categories so we can into whether their mic works or not. Just so oh, I see your pen. Are you able to make your mic work yet? It's okay if you can't. We'll see you in just a moment. So Sayeda, are you there? Can you chat? Maybe I'll use audio from. Ah, okay, it's 2 a.m. there. Yeah, I'm sorry. So do you want to try to weigh in on whether which of these three categories has inflammation? You'll never get these problems wrong again if you draw this like 3 times. And that's saying a lot. So which of these categories have inflammation, Sayeda? So give me letters. Give me like T, C, B. T, you're right. T has inflammation. So I'm just putting a positive sign, right? So what about what's the other one? What's another one? Ah, okay, don't know. Okay. So I'm going to ask Abad, are you here? Can you hear me? All right, I'm going to give you a few moments because we put you in the waiting room last time and you rejoined. So, so Helen, we're back to you.
Yes.
All right. So which one do you think has inflammation?
B and T.
So no. So this is a really important fact as well, and this is something I got wrong over and over and over again because I thought that candidiasis thrush
Mm-hmm.
doesn't cause inflammation. I thought that was true because it's a fungal infection. And I was thinking most bacterial infections cause, xanthomas or things that like not xanthomas, but like problems with your skin. They cause a lot of like, cutaneous infectious, things. So I was thinking it probably wouldn't cause, it would cause inflammation, but it's actually Candida.
Oh.
So if you have, white, kind of cottage cheese, no smell, then you actually will. Do you know how you identify whether there is inflammation or not?
Mm.
What are we seeing on physical exam that would suggest that there was inflammation?
Itching or something.
Yes.
Symptoms.
Yeah, itching, redness, even potentially, a little bit of there can be even like, bleeding and so it's like inflammation of the skin, so there's going to be damage to the skin. And so if there's damage, then it could itch. It could be red. It could be painful, And so
Okay.
these are all things that you might see. Another thing about vulvovaginitis is that's caused by Candida is you'll see, like if this was the vulva, you'd see like red dots. Like it's not going to be like red like diffusely. It's going to be like red dots on the skin. And so that's one thing that they call them like satellite lesions. And so that's great. So like we have inflammation. So another thing is I wanted to ask, we can keep going. So what test would you do to identify whether there's a smell?
You can do high vaginal swab.
Exactly. And the kind of like what they call eponymous name, eponymous meaning you don't have to know this word, it's just a nice word. Eponymous meaning like it's a person's name, or it's like it can be just like a word that they're using is the whiff test. And so this is a KOH preparation. that causes it to smell like you were saying, you know, and so if it is more evident if you do this test that it would have a kind of like a fish-like smell. And so that's how you're doing that test to identify whether there's a smell. So we have another category. Do you guys know what are some other categories that we use to identify? I'll just ask. So Abad, are you here? Can you make your microphone work so I can hear you? One of the requirements we have is that the mic works, and that's just because a lot of people speak up, and we're recording the session and everything. And so when we put people on the spot, we like to prevent other people who aren't answering questions from being in their presence and kind of causing people to feel nervous to speak. So I will put you in the waiting room. If your mic works, I'm just going to ask you to test it real quick when you come back. You're very, very welcome to join us. But I do have, that's the one requirement I have. I don't make people pay to come to the session, but I do want that to be going on. And so anybody know what another category of bacterial vaginitis like thing you might pay attention to? So this is specifically the itching. I believe this is the itching. Let me make absolute certainty, because I don't want to teach you the wrong thing. I make this diagram, and I took my exams, and now I don't reference it as much, but vulvovaginitis, and I'm going to look at my drawing. So what we're looking at here is so now we're talking about pH, right? So we're going to have increased pH in B, and we're going to have increased pH in T. All right? And so that's another thing that they love to test on. These are extremely high yield questions. You will see these all the time. So you got to get comfortable with these if you're going to take the exam. And so what does it mean? Is it acidic or alkaline if the pH is going up?
Alkaline if pH goes up.
Sorry, Helen?
If pH goes up, it's alkaline.
Yeah. And so I'm going to ask you a hard question. And so what is the threshold for a increased pH? So this is a really hard question. So I don't expect you to just belt out normal pH. But the vulvovaginal normal pH range is 3.8 to 4.2. Do you know what it would have to be above in order to be alkaline?
7, above 7.2.
Yeah, so that's a good, I think you're thinking urine, and so
Yeah.
that's a good instinct, but it's 4.5. So it's pretty close to the upper range. So like 3.8 to 4.2 is normal, and we're talking about this, right? So this is the normal range, and then above 4.5 is alkaline. And so if you're above 4.5, you only have to consider bacterial or trichomonal, right? And so what will Candida be? Will it be alkaline or acidic?
I think Candida will be acidic.
Yeah, so it'll actually be normal. And so that's another thing is if they're talking about a abnormal pH, you only have to consider B and T as well. And so thank you guys for speaking up. And this is a subject that like every time I talk to people about the answers to these questions, it's a foggy area, but it is absolutely in the top 50 highest yield subjects, I would say. You're going to have a question or multiple questions on this. And so it's my like soapbox to talk about it and make sure that you're absolutely up on this information, because I don't know why it's neglected, on occasion. And not that you guys are neglected. You guys seem to know actually quite a bit about it, but the pH is an awesome thing to know for test day. And so what do you see on by the way, I don't put this on my diagram, but what do you see in bacterial vaginosis on, like, if you in the lab, like if you were going to look at it under a microscope?
Cells.
Yeah, you'll see cells, right? Because it's bacteria, right?
Yeah.
And so what do you know what those cells tend to be called?
Clue cells.
Yeah, clue cells, exactly. And so you'll have like, clue cells, and there's like little like kind of like, hematoxyl, eosinophilic kind of areas on the outside. They're usually pretty white cells with a nucleus on the inside. So they're pretty like transparent cells. They look kind of light blue usually on the preparation they use to visualize it. And then do you guys know what you'll so this is usually the whiff test is usually bacterial vaginitis that causes like the amine odor, like the KOH prep causes the amine odor. So this is usually the fish smell. And this is malodorous, right? And so what do you usually see under microscope for T? Do you guys know? You usually see like a motile. They call them a motile trichomonad. So it's trichomonas, right? And it's a motile trichomonad. This is like a weird little critter that under microscope you'll see it. It look like pond water. There's like insects crawling around in the pond water. This is an actual organism swimming around. It is very clearly not bacterial vaginosis, because it is moving around. It is not like a cell. And then, do you guys know what you'll see for Candida? This is a more commonly understood kind of like laboratory finding for Candida. So do you guys know what a Hyphae is? Are you guys aware of what, like, Dr. Bazithra, have you heard the word Hyphae?
No.
Okay, so this is awesome. This is like, we needed to go over this, and so a Hyphae is going to be like a Hyphae when fungus is the only thing that you'll ever hear the word Hyphae about. So Hyphae is an anatomical characteristic of fungus. And so Hyphae are these like branching like limbs, right? So a pseudohyphae is going to have like pseudohyphae is going to be one wherein there are what appears to be branches, but they're like separated by these kind of like, so a real Hyphae will have maybe have septa, And a pseudohyphae is going to have like if I'm drawing the same image with pseudohyphae, it'll have like little have you ever seen a clown with balloon animals?
Yeah.
So there's like little areas where when he makes a balloon animal that he turns the balloon and there's like a little thin part of the branch, you know? If you made pseudohyphae with a balloon, then you would like turn it every time there was a septum. That's what they're referring to when they say a pseudohyphae, is that it's not really a branch. It's like a bunch of like these weird connected segments that there's like an angle in here, right? So that's what you're looking for when you're looking for a Candida. And they will distinguish Candida from other fungus that way. So that's what you should be seeing here is like pseudohyphae. And usually it'll be branching. So that's a sign that you're dealing with Candida albicans, because that's the weird thing about Candida albicans. But these drawings are not part of my diagram. These are just things that you need to have down cold. So these are images that you should go to one really good channel for step one to understand the material is a really good YouTuber called Dirty USMLE. And he has a kind of an audio Q bank that you can go to and watch, and he explains that there's this video where he explains images that you'll see on the USMLE, and it's really good right before test day and also really early on in your prep, just to understand how many images you really do need to memorize. And that's one of them. Pseudohyphae is definitely one of them. So sorry, my developer's asking if we should get a new version out for you guys to see. And so let's jump over to and so how would we treat a candidal infection? So I'm going to ask Helen.
We can give ketoconazoles, azoles.
Yeah. So not keto, but do you know another azole?
Okay.
So fluconazole.
Azole, okay.
So you got that. I'll give you that one. That one was a good. So that's a good impulse. Is like if you see azole at the end of the word, that's the candidal answer for sure. Why do we know that? Because this is fungal, and if it's a systemic infection, then you might use something else. But if it's limited to the vulva or the vagina, then you use fluconazole. And so, do you know what these other two categories you might use to treat them?
Can you give them antibiotic combination of antifungal, antibiotic,
Yeah.
and anti-inflammatory?
Yeah. So one that you would use for both is a drug that you have to be careful about drinking alcohol because it can give you a disulfiram-like reaction. And that's called metronidazole. Okay? But what I do in my diagrams is if there's something shared and you know that metronidazole is used quite a bit, then eventually you become familiar with the fact that metronidazole is a very commonly used vulvovaginosis treatment. And so I actually don't put that in my mind's eye to remember because I am eventually going to know that. And so I want to remember the things that I cannot necessarily remember. And so I will leave metronidazole out. And I'll put a C here. Do you know what this treatment is? It's an alternative treatment to metronidazole, clindamycin.
Okay.
And so now, what do you have to remember? We're going to momentarily move to a new sheet. Do you guys remember the letters at the top? Just shout it out.
BTC.
BTC, right? So for your exam, you're going to be able to draw this on your piece of paper. So which are the two that smell?
BT.
BT.
Exactly. So you draw out a stupid diagram like that. And then which ones have inflammation?
TC.
Exactly. Easy, right? So which ones have increased pH?
That's PT.
BT. Yeah.
Exactly. Easy. You will get all of these questions right. Not 99%. All of them, if you can draw this. But you have to remember, this is smell, this is inflammation, this is pH, you know. And then how do you treat bacterial vaginosis?
Give metronidazole and plus clindamycin. Clindamycin.
Great, great. That's perfect. So what about T?
Metronidazole.
Exactly. I won't even write anything because these are both metronidazole. And then what about C?
Fluconazole. Candida infection.
Exactly. So if you guys can remember the categories and you can draw this out, I'm telling you, this is how I do it. It's not the only way to do it, but this way works. It can work. I can't say that it works for you, but that's just a consideration. You might consider doing that. So all right. So let's get started playing the game here. So can I ask, Tala, are you here? We just did a mic check for everybody. Oh, okay, welcome. Tala, have you been to sessions in the past?
No, it's just my first time.
Oh, amazing. All right. Well, you're very welcome. So where are you coming from?
I'm from Sudan.
Oh, wow. Okay. I think you're our first Sudanese. So you're very welcome. Thank you for coming.
Thank you.
All right. All right. So let's open up a version of the game. I'm going to move this. You guys probably won't see that it's being moved. And then I will open up a copy of the game. All right. All right, I'll open a version. Multiplayer is on the horizon. I'm very excited to show you guys multiplayer, but it is not happening today. So can you guys see that?
Not yet.
Okay, what about now?
Yes, you can see it.
Okay, okay, great. So do you guys have a preference on what character we are? I ask this every week. So why don't we play the hardest thing? No, yeah, we'll play dwarf this time. All right, let's see if dwarf movement might be really costly right now. Yeah, it costs a lot. All right, we're gonna have to get a lot of questions right, guys. So I'm gonna upgrade this, and I'm gonna upgrade this all the way. Okay. So now I'm putting it into my skill slot. So one thing is we have Tala here. We're skilling up some skills. We're putting in our spell slots, and so we can use hotkeys to elicit those spells. And then I have here a movement and attack and picking up items. And what we do is we earn action points in an economy that is produced by the accuracy, speed at which we answer questions, and the confidence with which we answer questions. And we just go through and we ask people to turn their mic on when we're asking a question, and kind of they attempt the question, they read the question, and then we pause it and we talk about it a little bit, and then we get them to choose an answer in a confidence level, and then we discuss the answer, whether it's right or wrong. Doesn't matter. We're just learning as we go, and maybe discussing it a little bit. So, Tala, do you want to try a question?
I'm not sure, but I will try.
That's okay. Yeah. What happens is, even if you don't know the answer, we talk about ways that we can try to answer questions we don't know the answer to, because that's like I would say that's like 40% of getting a good score on the USMLE is just trying questions you don't know the answer to. So, let's try it. I'm gonna open up this question by clicking this button here, and I'll make the question text a little bigger. So can you see that?
Yeah. Yes, I can see it.
All right. So do you want me to read or should you?
As you know, I can read it.
Okay. So 40-year-old man. Can you
Me,
yeah.
I should. Yeah, me, I should say that.
Yes, if you want, if you would, I'd have you read if you want to.
Okay. You can read.
Oh, okay. So 40-year-old man with persistent moderate asthma presents with pulmonary function testing. His ratio is of forced expiratory volume in 1 second to forced vital capacity, FVC, is 0.69. Okay. And his FEV1 is 65%. So of predicted values. So what other findings can be expected in the remainder of the pulmonary function test? So I'm going to pause it for now. So what are you thinking when you read this question?
I know there is. We can think about constructive pulmonary disease, and we can think about restrictive.
Yeah, exactly. So I would even I would say the category of the question is pulmonary or respiratory, and you're trying to decide is this restrictive or obstructive potentially.
I'm not. I'm not sure about the value, but I will go with because I cannot recall, but maybe it's just for guess, maybe restrictive. I don't know really. I don't know how to.
Yeah, no, that's okay. We'll just, as much as you can talk, as much as you can say about what you're thinking about, the better. And then we go through, nobody's born knowing the pulmonary function testing percentages, So, so the ratio here that you're really concerned about or thinking about is 70%. So if it is above 70%, would you say that it is likely to be restrictive or obstructive?
Okay. If it is above 70%. So, well, I don't know really. I'm
That's
sorry.
okay. So this is how I want you to think about this every time you do a pulmonary function test question, and you will never have a discrepancy between which it is, because we're going to think about what is FEV1. What does it stand for?
The amount of air that's come out in the first second of when you are going to do like force expiratory volume.
Yeah.
Yeah, it's already there. Okay.
Yeah. And so, but you explained it beautifully. So it's when you start exhale, 1 second elapses, and it is the amount of volume that the air that comes out of your lung takes up. And so,
Yeah.
it is a measurement of volume, and then we are comparing that to a predicted value for your age. And so, would you expect that if somebody couldn't expire quickly?
Yeah. It's not restrictive. It's
If you can't expire quickly, it's probably is it obstructive or restrictive?
restrictive. If you can, I don't know. I go for restrictive because
Yeah.
like
So I'm gonna challenge you and say that it is obstructive, and I think you're going to be able I think you're going to be able to like intuit that when I tell you the way that I think about it, which is like, if you have, what is an obstruction? What does it mean to obstruct something?
to block the way. I mean.
To get in the way of a flow, right? Like, or a movement of something. So something has a trajectory, it's trying to move somewhere, and you're in the way. You're blocking it.
Yes.
So you know, I mean, you really know that if I'm blocking air, that the FEV1 is going to increase. Because it's going to take longer for the air to get past the obstruction, right?
Oh yes, yeah. Okay.
It's obstructed. So, you know, if it was a football team and they were more obstructive, then the ball would take longer to get down the field. If it was a river and there was a boulder in the way, then the water would take longer to flow past the boulder. You know, so the FEV1 is a measurement of the volume that you're getting in a certain period of time. Obstructive is definitely going to be the one that slows that down, right?
Yeah.
Now,
yes.
you could say, well, if it's restrictive, then it sounds like it's restricting flow, right? But you don't want to think of it that way. You want to ask yourself, if I know that an obstruction certainly will slow it down, then I can rule out the idea that a restriction will slow it down, right? So obstructive will be below 0.7 or 70% of predicted. So you've actually done very well, because you read this question and you knew that the pulmonary function test is intended to identify whether it is an obstructive lung disease or a restrictive lung disease. And so this percentage, what does this represent? If you had 100%, how would you put that in a sentence?
Oh.
I'm picking on you because you're doing well.
Because like
yeah.
If it's 100%.
Yeah, if it's 100%, let's say that this FEV1 FVC ratio was, let's say that we're just talking about FEV1. How would you put that in a sentence?
Definitely the volume in the lung is really very, very low. Like it's in...
So the forced expiratory volume in 1 second, meaning the amount of air that you're getting out of your lungs in 1 second, is exactly or above the predicted amount that I would expect if you were normal and healthy for your age. Right?
Mm-hmm.
And so what is forced vital capacity?
First vital capacity. It's when you when you first vital.
So a capacity is a just so you think about this the right way for when you're trying to memorize the volumes and the capacities. A capacity is the sum of two volumes. So you're taking
Yes.
two volumes, you're adding them together, and you're getting the FVC.
The force of inspiration and expiration together, right? The whole amount.
So FVC represents very specific volumes that are being added together, right?
Mm.
So this is a hard question, but I'm going to ask you, what does FRC equal? They love to ask this question, like, what do these lung volumes equal in terms of adding them together? So it's your end reserve volume, it's your expiratory reserve volume and your residual volume. So I feel bad even talking about this and not giving you a diagram. And I don't own a diagram for this. So I'm going to draw it myself. And so let's do that. I'm going to grab a paint pad and we'll just draw it. So if I drew, let's say that I had like zero air here. And then on expiration, let's say that I'm just labeling this axis. This is your volume axis, right? So this is a terrible drawing diagram. Okay. The reason is my mouse pad. So we're going to go boom, boom. And so we're going to have 1 here, 2 here, 3 here. Do you know how many liters the lung fills up with? This is all like really hard questions. I'm giving you like really hard questions. And it's your first time. It's not very, I won't always be, I love this category of knowledge as something that we all need to study. And I need to see it as many times as I can a year or I'll just forget it. And it's really hard to remember. So I think it's a really easy subject on test day that you can pick up points really easily if you can draw this out. So that's why I'm doing what I'm doing. So between 2 and 3, between 2.5 and 3, you're going to have what is called like tidal volume, right? And then if you were to inspire as hard as you could, you would have your inspiratory capacity, which is to say right here at the top, your inspiratory capacity will be, this is your maximal inspiration, which is your inspiratory reserve volume plus your tidal volume. And so this is your tidal volume. And so it'll be this plus this, right? Will be your inspiratory capacity. Don't try to memorize this. Just try to hear what I'm saying and then go into it later and kind of look into it later. But don't try to memorize what I'm saying because it's a lot to take in. But this, so then there's tidal volume again. And if you were to exhale without really forcing it, or if you were to exhale and force it all the way, I should say, then this would be your maximal expiration. And so your below your maximal respiration is something called your residual volume. And this is something that like increases in like something like COPD. So you'll actually have an increased residual volume in COPD. So then you have your expiratory reserve volume, which is between your tidal volume and your maximal expiration. So that's here. So this is added. Potentially, and actually, I'm not even going to put it that way. I'm just going to say this is your expiratory reserve volume here, just this. Okay? That means it doesn't include the residual volume. It doesn't include the tidal volume. Okay? And so this is in excess to your residual volume. So if I start talking about a capacity, I have to add some of these volumes together. And there are more volumes that you should go through and understand and everything. But you have your inspiratory reserve volume, which is just this area here. And you have expiratory reserve volume, which is just this area here. And your FRC, long story short, or long story long, I should say, your FRC equals your end respiratory volume, which is to say when you force air out of your lung, it's the amount that you were able to force in excess to your normal breathing. So your forced expiratory volume plus your residual volume. Don't get overwhelmed and don't think like this is, oh my God, this is so much information, because you're going to see this a million times. I guarantee it. So this is FRC. FRC equals end respiratory volume plus residual volume. So that is all of this volume. Okay? So that's a really
yeah,
long
okay.
explanation, but you can see why it's necessary to understand your volumes,
Yes.
because in order to define what FRC is, you have to know this whole chart. So when I ask you what FRC is, I'm being very rude, and you've done very well so far. We're talking about pulmonary volumes, and you gave me FEV1 immediately and identified that this was restrictive or obstructive, and we have to identify which it is. So when they talk about the ratio, they're talking about FEV1 as a ratio to FVC in terms of what you would predict a normal person to have for that age group. And so they have charts. You're not supposed to memorize what they are because they're just going to give you a percentage out. And that percentage, if it's above 70, is it obstructive or restrictive? It's going to take longer if it's a lower percentage, right?
Yes, it's obstructive if it's less than 70.
Exactly. And so if this ratio is 65%, is that abnormal?
65%. It's less than 70, right?
Yeah. So that's abnormal,
Yes,
right?
so it's not normal.
Yeah.
Yes, it's obstructive.
Yeah, it's obstructive, exactly. And so what are some obstructive lung diseases?
Bronchiectasis.
Yeah.
Asthma. It's
Yep.
yeah. Yes. Okay, and then what else?
And then there is bronchitis.
Yeah. Okay.
Which is a form of COPD, right? And
yeah, COPD clapping. Yeah.
So COPD includes emphysema and chronic bronchitis, and then you have asthma is also obstructive, but it's not part of COPD.
Okay.
And so those are your obstructive. In terms of restrictive lung diseases, do you know some examples of restrictive?
Restrictive, like
It's okay if you don't. This is perfect because this, like, the categories of knowledge that you guys should do, potentially go through first aid and just like hammer on first aid. Just think about first aid for cardiology and pulmonary and renal. And really think about this pulmonary function testing in your pulmonary section. And really think your pressure volume loops in your cardiac sections. So you do not need to prepare for these sections, and we will not.
I'm sorry. I came just like to see, and I didn't prepare. I didn't read.
No problem. This happens to. You'll see that a lot of us get questions wrong, and we need to go over this material. And I'm picking on you, especially if you watch the videos where Wenda's going to share the YouTube channel with you. We do this all the time. So you're doing. I'm not just blowing smoke. You're doing very well.
No, but it's really nice. Thank you, Wallah, for this.
Good.
I get like motivated. Yes, thank you.
Yeah, everybody's benefiting as well. I can tell you that not almost no one is memorizing this lung volume chart at this point in their studies. I would imagine. I don't mean to speak for everyone, but this is not an easy topic. It seems like an easy topic until you get into how are we deriving these answers? Yeah, so Sayeda is saying she's learning a lot. Okay, yeah. So thank you for saying that, Sayeda, because that's exactly that's how I feel. I get to recapitulate this material. It's not easy for me to come up with what I've memorized either. This is tricky, you know. So in terms of diagnoses for restrictive lung diseases, we have, you know, in a young person, you might have cystic fibrosis. If you hear the word fibrosis, you know, a fibrotic lung disease, a disease that involves, you know, fibrous tissue, it's going to cause it to be harder to expand the lung. And so it's harder to be able to get air into the lung. And so your expiratory speed at which you're going to be able to get air out of your lung is going to be slow. It's going to be normal or fast, actually. So it's going to be easier to expire potentially, if anything, with a restrictive lung disease like pulmonary fibrosis, or if you had ankylosing spondylitis, which is a form of like it's actually a sacroiliac kind of like a bone affecting thing. It can cause like fusion of your vertebrae and things like that. Don't memorize this stuff. Just kind of hear it, and you'll hear it over and over again as you study. But ankylosing spondylitis is another thing because your chest wall is not moving as well because you have it's called ankylosing spondylitis. So it has fusion of, you know, bones and connective tissue, and you winds up being harder to move your chest wall. And that's a restrictive lung disease. So it's really more about inspiration, which is to say breathing in for inspiration, than expiration. So that's why they're doing this test. They're trying to decide, do you have problems breathing out or breathing in? That's what we're really asking. So if you're restrictive, you're having trouble breathing in. And if you're obstructive, you're obstructing air as it goes out. But the way to remember it is in, you know, is inspiration, and X is expiration. And, you know, and you want to remember that if this percentage is low, you have obstructive. And you know what this percentage is. It's forced expiratory volume. So it's expiration. So slow expiration is obstructive. And so that's how you want to take that apart and think about it. And you want to be thinking really deeply and because the highest yield stuff is not the stuff you memorize. It's the physiology. It's the understanding that applies to so many different questions that when you arrive on test day, you're able to answer questions on the basis of what you understand as opposed to what you've memorized and know. And I say that, and people don't quite understand what I mean by that. Like they think that I mean that it's better to understand than it is to memorize. That's not what I'm saying. I'm saying it is higher yield, and you will get more questions on test day focusing on physiology than pathology. You will get more. And so physiology is so useful, and people go into like tutoring sessions with me, or they wind up like knowing all of the memorization, but not going back and realizing that their physiology is not there yet. And once they fill it in, they wind up doing really well on these questions. So let's get back to this. And so a decrease in FEV1 with albuterol. Do you know what that represents? This is a very it's a high yield question, but it's like, you know, you either seen it before or you haven't. It's not. So is asthma reversible? I'll just ask everybody. So I'll ask Helen, is asthma reversible? Helen, are you there?
Yes. Yes.
Is asthma reversible?
Yes, it's reversible. Yeah.
Yeah. So is emphysema?
No.
No.
So somebody's been studying U.S. Assembly. Yeah. So so no, right? Emphysema is not, and is chronic bronchitis?
No.
No, right? And so Dr. Bazithra, So thank you, Helen. So Dr. Bozithra, are you there?
Yeah.
So how would you know whether something was reversible or not in terms of lung diseases, pulmonary function? What you would do is you would give albuterol or a beta agonist drug. So beta adrenergic receptors dilate your bronchioles and open up the airway. So if you give a beta agonist, it should open up the caliber of the bronchiole, and it should make it easier to breathe if you have an obstructive lung disease. But in COPD, it doesn't work. And so it only works in asthma. And so you should expect like a 12% improvement in your FEV1 FVC ratio compared to predicted when you take a beta agonist drug like albuterol.
So it's supposed to say increase in FEV1 with albuterol.
So if you increase the amount of volume per second, then you're improving your obstructive lung disease. So you're absolutely right. If this was asthma, you would expect an increase in FEV1, not decrease. So we can rule that out. That's a great point.
Yes.
Yeah. And so we'll come back to tala here. So decrease in diffusion limitation of carbon monoxide. Have you seen this before? DLCO? So DLCO is a test where they give you carbon monoxide, and they're trying to get an impression as to whether or not you're able to diffuse oxygen or carbon dioxide through the alveolar wall. Are you familiar with the word alveolar?
Yeah.
Yeah. So you have, this is a really crude drawing, but you have this guy's mouth, and it's coming in. Then you have the lungs. So you have the trachea, right? And then you have the lung. And inside the lung, you have a bunch of these balloons called alveoli. And then if you look at one of these alveoli really close up, there's a wall to the alveoli. And then you have blood vessels here. I'll draw it in red. You have blood vessels here that are trying to get the oxygen through the alveolar wall. And if you have a fibrotic lung disease, there's going to be all this fibrous tissue between the alveoli and the vasculature. And so you're going to have a exacerbated or worsened DLCO, which is your diffusion of carbon monoxide. And so that means that your respiration is affected. So you would see this in something like emphysema, where the alveolar walls are destroyed. Or you would see this in pulmonary fibrosis. And so if you have an intrinsic restrictive lung disease, which is almost everything except ankylosing spondylitis in terms of your restrictive lung diseases. So is emphysema one of our categories of pathologies that has decreased FEV1 FVC ratio like this patient? Yes, but we know that he has asthma. They tell us that he has asthma, right? And so this would represent emphysema. And so we wouldn't choose that one. So I'm just going to let you guess the answer now, and then we'll just look at the answer and we'll move on for people. But this is a great question, and I'm so glad you were willing to be first up. I'm sorry to ask you to speak first, because you're going to see we do this a lot. So what would your answer be if you had to choose?
Okay, wait. Increase fraction exhalation. Decrease in total capacity. I'm gonna choose E.
E, okay. What confidence do you want to put?
What?
Should we put green, yellow, or red?
Green.
Let's do green. Okay. So it looks like it might have been. So it was increase in fractional exhalation. So then what we do is we go to the review category and we can actually read the explanation. And so we know that this person had asthma, and it's defined as a reversible airflow obstruction. So if you took albuterol, Bazathra was exactly right. The albuterol would increase the FEV1. And you're right. We're trying to decide whether this is obstructive or restrictive. So if you look at the FEV1 FEC ratio, it was below 70, so it's obstructive. And what you would do is you would give a methacholine test, but the FEV1 would not be increased with methacholine, right? Because methacholine is going to make it harder to breathe. And so that's what methacholine is the opposite of a beta agonist. And so you're going to be actually restricting the bronchiole into a smaller column, and air is going to have more trouble getting through. And so that's what's wrong with B. And so if you look at the last two answer choices, D and E, a decreased total lung capacity would be something like a restrictive lung disease. And so you know that that's not the answer because we had a decreased FEV1 FEC ratio. And then if you look at D, the increase in fractional exhalation of nitric oxide, this is a hard question. Tala, you did very well. This is a hard question. This answer is rough because the fractional exhalation of nitric oxide, what are we talking about? The fractional exhalation of nitric oxide. So nitric oxide is produced by endothelial cells in response to bronchoconstriction. So high levels of exhaled nitric oxide, at least 50 parts, you don't have to know this number at all, suggest airway inflammation, suggestive of potential asthma. And so in asthma, you will have bronchoconstriction. We know that because you don't take beta blockers and things like that, things that will block beta 1 when you have asthma because of constriction. And so high levels of exhaled nitric oxide suggest airway inflammation, suggestive of potential asthma, because the pathophysiology of asthma is such that inflammation is the cause of the disease. And so this is a test that we do. I think you just have to memorize, really, that nitric oxide is associated. An increase in fractional exhalation of nitric oxide is your asthma answer. That's how I would understand this question. Even after everything we said, that's the thing that you had to know. So it's really not a very nice question, and I really appreciate that you were willing to go through that because a lot of people benefited, I think. So thank you, Tala, and Rowenda, who do we have next?
Yeah, let's try Helen.
Helen, okay.
Hi, Helen.
Hi.
Welcome back.
All right, so I'll let you read because you know the drill here. Okay.
Yeah. A 45-year-old Caucasian male with a history of chronic myeloid leukemia, for which he is receiving chemotherapy, presents to emergency room with oliguria and croaky left flank pain. His serum creatinine is 3 and his urine pH is 5.
Right.
You diagnose nephrolithiasis. His kidney stones, however, are not visible on abdominal X-ray. His stone is most likely composed of which of the following?
Yeah, so what are you thinking about? Not answer choices, but like what are you thinking about when you read the question? So the first thing I would do is I would say, what category of question do you think this is? Is this a pulmonary question? Is this a pulmonary question?
No.
No, right? So what category do you think?
Blood, because of leukemia, he got stones.
Yeah, so you could say this might be oncology, which would be cancer. So this might be a cancer question, but it could
Yeah,
also
okay.
be It could also be a like a nephrology question, like a kidney question.
Yeah.
So that's why they say reading first aid is so useful. And I didn't understand this until late in my preparation is I think the first thing that people skip, not that you skipped it, I skipped it when I was studying, which was a pain in my butt because I wound up like not understanding what category of information I was learning. And then I would forget it because I was like, okay, well, cool. I'll remember that. And then I wasn't remembering it in the context of a kidney question. I was just trying to remember the information. So this is probably a kidney question. It might be informed by some oncology, but we're thinking about kidney stones. That's going to be in your genitourinary / kidney, question kind of category. And so, what are you thinking about in terms of like what types of stones are there?
Um, um,
So there is uric acid stone.
yeah, uric acid.
So you'll notice like one of the things they did is if you read the answer choices, like a lot of people will read the question sentence, which is like his stone is most likely composed of which of the following. Sometimes you read that question first, and then you glance at the answer choices, and then you go up and you read these areas. I really like that strategy sometimes. So you read this question, and then you read these answer choices to give you like a feeling of like, what category of knowledge is this? And then you go up and you read, and you try to picture the patient from the first sentence, which will usually tell you like what they presented with, what was the like thing that they came in complaining of, And so this are you do you feel like strong in this question, or should I think through it a little bit with you?
Yeah, I'm thinking about the uric acid, maybe because of
Yeah. Why are you thinking uric acid?
because of chemotherapy he's receiving.
Yeah, so if you got chemotherapy, you would get potentially more uric acid, right?
Right, yeah.
So why do you you're absolutely right. Why do you associate uric acid with chemotherapy?
Yeah, maybe because of some drug side effect, build up a uric acid.
So what happens is you have a cancerous cell, right? And then there's DNA in it, right?
Mm.
And so when you give chemotherapy, you lyse the cell, and everything that's within the cell comes out of the cell. So now you have what was already uric acid, but you also have DNA that's coming out of the cell, right? As well as potassium and sodium, right? And calcium, but you have a lot of DNA, and in that DNA you have thymidine, you have adenosine, you have guanine, and if it was bacteria, you'd have uracil, but you have cytosine, and so your A's and your T's become, so you have adenosine that gets metabolized into hypoxanthine, and then it becomes xanthine, and then it becomes uric acid. Because right here you have an enzyme called xanthine oxidase. Have you heard that term, xanthine oxidase?
Yes.
that is a very common site of drug, interaction. And so a lot of drugs will target xanthine oxidase. And so uric acid is actually a product of xanthine being converted by xanthine oxidase. And so your gout drugs, this is the target of your gout drugs. Usually. And so preventing, uric acid. And if you have too much uric acid because you're producing too much DNA, because that DNA is being broken down into adenosine, and that adenosine, which is a nucleotide, and so then it becomes hypoxanthine, then it becomes xanthine, it becomes uric acid, then you can associate chemotherapy and cell lysis with increased uric acid. Right? And so what people do to avoid uric acid is they give resburicase, which converts uric acid to something called allantoin. And allantoin, unlike uric acid, is soluble in urine. And so you can excrete it in your urine and get rid of it in your kidneys. And so animals have this, like your dog has allantoin, but humans don't. And so we get gout. And so what resburicase will do is allow for uric acid to be converted into allantoin. And so that's how you treat something called tumor lysis syndrome. And so that's what this question, I think, is getting at, is when you have chemotherapy, what is released? DNA, and that becomes uric acid. So what kind of stones are you going to see in the patient after you give them chemotherapy? So which one do you think they... Yeah, uric acid, right? So what confidence are you thinking?
Green.
Green, yeah. This is a like, I'm sorry for the lengthy, I'm giving really lengthy explanations this time, but these are you absolutely had the right instinct with thinking it was uric acid because of the chemotherapy, and I'm just explaining it out so that other people can kind of think of it the way that you're doing it. So now we can move again. It's very, very slow going when you're a dwarf. There's going to be some spells that you can cast as a dwarf that will allow you to move quickly. But thank you, Helen, for doing that with us. And so Sayeda, do you want to type your answers and then maybe someone else can speak them aloud while we go through a question? Does that sound okay? Rowenda, can you tell me what Sayeda's telling us?
Yeah. She said I'll do that.
Okay, thank you. All right, so I'll read the question for you. So, but just this once, okay? So let Rowenda know if you can't make a session because it's going to be too late and your mic's not going to work, for example. But so a 42-year-old woman is seen by her primary care physician for her annual checkup. So I didn't highlight anything. 42-year-old woman. So one thing I will do is I'll go, which of the following pathways is most likely abnormal in this patient? So I'm reading the question sentence, and then I'm looking at this looks like it's going to be a biochemical question. So I'm just noticing that, and now I'm going to read the question. So 42-year-old woman is seen by her primary care physician for her annual checkup. She has no current concerns and says that she has been healthy over the last year, except for a bout of flu in December. She has no significant past medical history and is not currently taking any medications. She has smoked 1 pack per day since she was 21 and drinks socially with her friends. Her family history is significant for prostate cancer in her dad and was 51 years of age with ovarian cancer in her paternal aunt. So she has a family history of ovarian cancer and prostate cancer when she was 41 years of age. Physical exam reveals a firm, immobile, painless lump. Okay, so now we're thinking about cancer in the outer quadrant of her left breast, as well as 2 smaller nodules in her lower quadrant of her right breast. So biopsy of these lesions shows small atypical glandular duct-like cells with stellate morphology. So which of the following pathways is most likely abnormal in this patient? So first of all, what category of question is this? Biochemistry, certainly. And then also potentially another category. So I would say reproduction, right? So because breasts are thrown into the category of reproductive organs because they change when you get pregnant. And so they throw it into reproduction. And really the only reason we have nipples and breasts at all is because when we're female, they can produce milk. And so evolutionarily speaking. And so we're talking about the biochemistry, but we're also talking about cancer. And so this is an oncology question as well. What kind of cancer are we dealing with? And what would we expect to be the mutation that produces this type of cancer? So a lot of people, when they start their, so breast metastasis cancer. So I would even say that maybe not even metastasis, maybe more like primary lung cancer. You know? Because she's healthy, except she has a lump in her breast. So I would say primary, do you know, like, maybe precancerous. So not metastasis necessarily, but like if we had a cancer in the lung, we might say, okay, this might be a lung metastasis. But because it's not traveling, it's primary, meaning it is coming from the origin, the breast. And so a lot of people, when they're starting their exam prep for USMLE, don't believe, they just do not believe that you have to know the morphology of the cells in breast cancer, in ovarian cancer, in cervical cancer, in colon cancer, in brain cancers. And those categories, testicular cancers, you really need to know the histology, and you actually have to make sense of whether they're small, atypical, glandular-like, duct-like cells. These terminologies come up over and over and over again, so you have to watch. You really should do yourself a favor and watch pathoma. Not to say that you don't know the answer to this, but if anyone didn't, which I'm sure a lot of people don't, because this is a hard thing to memorize, this is a very late stage in prep. Like, you're going to see it over and over again, but it's hard to remember which it is. Really get into the weeds and understand the histology, because that's where they like to test you a lot. And pathoma really does a good job of teaching that. So I'm going to write that into the chat. Pathoma is it's really a must. You should definitely go through pathoma. And so are you comfortable with breast cancer generally? Or you're kind of feeling like you don't know what kind of breast cancer this would be? No idea. Okay. So I'm going to put your chat actually into this. And so so that way people can see your responses. And so actually I'm going to blur your name out, and I'm not going to do that. But so if you're not comfortable with breast cancer, which is totally reasonable, then I think the word that I latch onto the most is that it is duct-like and atypical. So we know this is cancer. If it's atypical, it's likely cancer. And it's duct-like, meaning it's probably either invasive ductal carcinoma or another type of ductal carcinoma. Invasive ductal carcinoma is a very common type of carcinoma. And so do you know which of the following pathways is most likely abnormal in this patient? We have to know what the tumor markers are for certain types of breast cancer. And so why don't we answer this question, then we'll go through the explanation, because it's been a while for me too. So, why don't you choose an answer choice and then and choose a confidence, and we'll go over this. This is a hard one. So which one do you want? D. Okay. So I'd say this is a hard question to rule out. I think homologous recombination is a decent answer choice. And I think of these answer choices, yeah, it's a guess. Yeah, I totally understand guessing on this question because it's really a hard one. I think nucleotide excision repair happens a lot in questions. Base excision repair happens a lot. Mismatch repair happens a lot. So these three happen a lot in answer choices. So if I had to guess, I'd guess one of these, not because I know the answer, but because they come up a lot. They're like a subject in biochemistry that they really like you to know and understand. They like you to know whether the polymerase does it, which polymerase 1, 2, or 3 does it. So we're gonna say medium confidence here. I'm just gonna presume. So you got it right, Saida. So good job. So that was a hard one. So we're talking about BRCA1 and BRCA2, right? And so BRCA1 and BRCA2 increase your risk of many breast cancers. And so we didn't have to know that this was invasive ductal carcinoma, although we did. And it is associated with so ovarian cancer is another thing that BRCA1 will increase your risk of. And it also increases risk of prostate cancer. So prostate, breast, and ovarian cancer are joined in their risk factor of having BRCA positive, BRCA1 cancer, and BRCA, and so this person was likely BRCA1 positive if they have invasive ductal carcinoma. Another thing that I'm just going to tell you is if you're immobile, that's likely cancer. And another thing I'm going to point out is invasive ductal carcinoma has a very defining, a very likely characteristic on questions that you will have blood coming out of the nipple. So that red animation, by the way, is someone's attacking us. So we got to get some action points and attack them back. But that is what this question was saying. Is they're saying BRCA1 is a marker as a tumor suppressor gene, and that tumor suppressor gene, when it's messed up, is going to cause homologous recombination. So you need to just memorize that and then go through your genetics. And when you're going through your genetics, as you're learning what non-homologous end joining is, as you're learning what mismatch repair is, do yourself a favor. Memorize the tumor markers as you're doing these. Memorize what mismatch repair is, and then go back and say, is mismatch repair associated with a BRCA mutation? Is nucleotide excision repair associated with a specific tumor marker? Because they all are. That's what they're testing you. They're testing you on cancer by teaching you genetics. And so this is actually something that you do see on NBMEs for step 1. And so it's a good thing to know. I didn't know the answer to this question, but it's been a while since I took step 1. And this is a very nitpicky question, but it is also something that you really will see over and over, and that pathoma does really well. So thank you for answering those questions, Saida. I know that's a tricky one. I'm going to attack this guy who is a snake, apparently. And we're going to do some damage here. All right. Cool. So now he's bleeding, actually. This is a very morbid thing, but he hit them so hard with his axe that he bled, and he had a hypovolemic shock, and then he died of bleeding. Okay. So thank you, Saida. So Rowenda, who would be next in our list here?
Dr. Basit Rafat.
All right.
I'm here.
All right, let's do it. I'll hit the cue. You know what to do. Oh, we got another pulmonary. Here we go.
A 55-year-old man with a 60-pack-year smoking history is referred by his primary care physician for a pulmonary function test. A previously obtained chest X-ray is shown below. Which of the following is most likely appear in his PTF report?
All right,
Pulmonary function test report.
All right, so let's look at this diagram here. So do you have a method for looking at X-rays?
Yeah.
So what do you do first?
So you look at the You look at the cardiac shadow. You look at the
Yeah.
aortic arch,
Yeah. Over here.
arch of the aorta. Then you look at the blood vessels as well.
Yeah. So like coming out like the pulmonary vasculature.
Then
Those lung markings are vasculature, by the way. And not that you don't know that. I'm just telling everybody as we go along. And so I would say that everything you've said is correct. However, do you have like a system so you don't skip anything while you go through a chest x-ray? This is what I do. A lot of people do this. This is like A, B, C, D, E for chest x-ray interpretation. Have you heard of that? It's like
is it airway?
yeah.
A-
So airway first. So what would you do for airway?
You look at the trachea. Looks central.
Is it deviated? Is it central? Exactly. And so you look at the trachea, and you have bronchioles coming off here. This is the tracheal shadow, or like what looks like the trachea on X-ray. And so you might say, is that patent? Does it look like it has stenosis? Are there? Is it deviated to one side or the other? And then B is actually for bone. And so you look for fractures. You're looking at the ribs. 1, 2. I look at this side of the ribs. So I look at nearest the spine. So this is you're going to see both ribs that are coming off. So the ribs actually doing this, right? So you can count these ribs, but you can also count these ribs. So I'm going to count these ribs. 1, 2, 3, 4, 5, 6, 7. So I'm not seeing 10 ribs. I'm not seeing more than 8 ribs.
Yeah.
Yeah.
More than 8.
And that would be, what would that suggest if there was more than 8?
So it means the vessels are dilated. There is some inflammatory process which is covering the bone to be seen.
Yeah, so if there was more than 8, then you'd see more bones, right? And so what would that be associated with? I'm thinking about COPD.
Yeah.
If I'm seeing more bones, and the way to remember that is if you have like a barrel chest. Barrel chest refers to a chest that is hyperinflated because it's having trouble getting air out. And COPD, you're going to have air pushing down on the diaphragm, causing them to flatten. And you're also going to have hyperinflation causing you to be able to see more bones. And because air is transparent on the X-ray, when you hyperinflate, you make it more easy to access visualizing the bones behind the pulmonary vasculature. So we don't see that here. We don't see the flattening. We see the costophrenic angle here, which is a little V-shaped thing here, and we don't see the flattening of the diaphragm. And we also don't see more than 8 ribs. And so this is not COPD, I would say. Not on X-ray. So the next thing is you have C, which is for cardiac. So you have A, airway, B, bones. And you can also say B, breathing, right? You can look through the lung fields and see if there's markings everywhere. And then what is C? So you said aortic knuckle. You have
cardiac shadow.
Cardiac shadow, but also cardiothoracic ratio. If you were looking at like the size, so you'd look at the full length of the chest, and then you'd say, is the heart taking up more than 50%? Would you say that it's a large heart in that way or a small heart?
I think it looks like a large heart.
I would say that it's narrow, because if the heart was taking up 50% of this like X-ray,
you would see the sheer shadow.
You would see the beginning of the heart would be, here's the beginning of the heart, here's the end of the heart in terms of measurement for cardiothoracic ratio. And then the lungs take up more than 50% of the width. And so if I was measuring this, I would start from here and I would go here, and I would say how much of the cardiothoracic like length is taken up by this heart. And it's very, very small amount.
Yeah, so this is an average heart.
Yeah,
Normal
maybe
heart.
average to small, probably average, right?
Yeah.
And so I think you're right. So we've noticed these things. Let's go back to the question and kind of talk about what are you thinking? So this is a 60-pack year smoking history. Chest x-ray, I'm not sure that we identified exactly what we're looking at, but maybe we ruled out one diagnosis. What diagnosis do you think we ruled out?
I would go for either COPD or
Yeah, exactly.
Yeah, COPD because of the history of 60-pack a year.
Yeah, but given the x-ray, we can't...
Yeah, given the x-ray, it's not showing that it's COPD.
Right. So it might be COPD, but it's not showing it. And I would put it to you that they're not likely to write you the question and give you an x-ray that's normal and say that it's COPD. They might, but that's usually like a step 2, step 3 type question. In this question, they gave you that they're a smoker, but they could also have other diseases, you know? So you might be right that this is COPD. So if we thought this was COPD, which answer choice would we choose? Would you expect your residual volume to increase, stay the same, or decrease if you had COPD?
Residual volume to decrease.
Residual volume will go up. Residual volume will
increase,
go up.
Yeah.
Yeah.
To increase.
Yeah, and so you're increasing your lungs are hyperinflating, so the pleura is filling with air. And so your residual volume, the amount of air that is retained within your lung, like if you think about what does it mean to reside, to be residual? Well, it means to be left after something happens. You reside, you know, residual means like there is something that still exists after maybe it shouldn't be there anymore. And so with obstructive lung disease, when you're exhaling, you should be getting a lot of the air out of your lung. Not all of it, but a lot of it. And so your residual volume should be a certain amount. In COPD, it should be a larger residual volume because you're having trouble getting air out of your lungs. And so I would expect residual volume maybe to go up. So what do you think will happen to total lung capacity?
Would it decrease?
So actually, so think about what are we doing? We are obstructing the air from leaving the lungs, right?
Uh-huh.
So will we have more air in the lungs or less?
I will have more air because it will keep expanding.
Right. And a capacity what is a capacity? It's a volume plus a volume, right?
Yeah.
And so yeah.
Total lung capacity will increase.
Yeah. So which answer choice is going to correspond to COPD?
That will be C.
And so if you think it's COPD, you have to choose C.
Yeah.
If you don't think it's COPD, you can choose other options. But I'll give you a hint. This is one of the test-taking strategy. When they're talking about residual volume, when they're talking about total lung capacity, and they're only talking about residual volume and lung capacity, they're usually talking about COPD.
Mm-hmm.
Because those are the two things that you pay attention to changing in COPD. And that's the highest yield, most commonly asked lung volume question in terms of a change in lung volume, specific lung volume, I would say, is your residual volume change, your total lung capacity change in COPD. So that's a I don't even need to know the answer to get it right, and that happens a lot. You can answer questions that you don't know the answer to a lot. And so I could even diagnose this as I could probably choose this answer just reading the answer choices eventually. Because you're saying this is probably a COPD question and this represents COPD, so I'd probably choose this one.
Yeah.
So that's a nice thing to think about just as a proof, just as you're going through the questions, go, I'm not likely to choose anything else. So if I have to guess, or if I'm running out of time on the exam, I don't even have to read this, which is going to be, that's an important thing to do for me, because I take time to answer questions. So, so which do you want to choose? I'm helping a lot more today. Okay. So thank you for putting up with my. I'm explaining a lot more and not letting people just.
No, that's
answer
actually
it.
better.
Oh, good. Okay, I'll
Yeah,
ask people
I think
how
I
they
like
how
it
they.
more.
Okay, well for you that's what I'm gonna do, and I'll try to remember that.
So green.
Let's go green. Okay. All right, we got it. So that's a good. That was a good question there. Let's see what the illustration shows. So this is an obstructive distribution. This is a normal pulmonary function test, and this would be restrictive, where it's a lot. This would actually be obstructive as well. But the obstructive, the pattern of an obstructive when you have this little lip here, and that's because your expiration is going to take longer. When you have a obstructive lung disease. And so this chart, actually, the higher numbers are over here, the smaller numbers are over here. And so if you have an increased volume here at more inspiration, then you're trapping air. And so you got to go through these flow volume loops. Like I would bet you $100 that you're going to have a flow volume loop question on your exam. So you have to just know it. I guarantee you will have a flow volume question. I will be shocked if someone comes to me and says, you told me I'd have a flow volume loop question and I didn't have one. I will never experience that. You'll all have a flow volume. So that's a really good one to know. And so I have these items here from killing the snake. And here we are moving on to another snake. So that's one of the things is when we do these, we keep replaying the same stage because we're not buying the game and using it. We're just playing it for learning. So thank you so much. And Dr. Bazith Rafath. And so who's next, Rwanda, in the list, I wonder? We've been going for 2 hours.
All right. Yeah, let's go back to Tala.
Okay, Tala. All right. Would you like to do another?
Yeah. Yes.
All right, let's do it. Okay. So you see, we're thinking about this stuff. It's like, I mean, like we just go through the questions really. So do you want to read or should I?
Okay, you can read.
Okay. So what I'm going to do I like this idea where I'm going to highlight the question sentence, which is how I do it. When I'm doing questions, that's what I do. I read the question sentence. What is the most likely etiology of this patient's symptoms? And then I glance, okay, this looks like I'm going to identify a pathology. A specific organism. So then I go to the top. A 53-year-old man. So I'm looking for causes of a pathology and differences between these things. So Louisiana Gulf Coast community. All right. So 48 hours of profuse watery diarrhea, not bloody. 24 hours of vomiting and chills. So he has vomiting and chills and diarrhea. Patient has last medical history significant for hypertension and hypocholesterolemia. The patient denies sick contact, so it might not be an infectious cause, or any interaction with animals for the last month. So 2 days ago, the patient attended a family crawfish boil, where oysters, boiled crabs, and crawfish were consumed. Stool of cold blood was negative. What is the most likely etiology of this patient's symptoms? All right. So what are you thinking about, first of all? Like, what category of question is this?
For sure, it's for microbiology.
Exactly. And so, what are you thinking in terms of categorization of diarrhea?
Bloody and non-bloody diarrhea.
Yeah. And I would say acute or chronic.
Oh, okay.
So if this is 48 hours, would you say that's acute diarrhea?
Yes.
Exactly. And so now you really know a lot about this diarrhea. It is acute and it's watery. Right? So which of these answer choices causes bloody diarrhea?
Bloody.
Yeah.
Maybe Shigella.
Yeah. Dysentery is a bloody diarrhea. It starts watery. Ebola, I'm sorry, E. coli would start watery and become bloody. Shigella is invasive. It goes immediately vertically down into your mucosa and it causes bleeding. So Shigella is a great answer. Do any of these others cause bleeding? Not an easy question.
I'm not sure, but maybe I guess. What about Campylobacter? But I'm
Great.
not sure.
That's a great answer. So Campylobacter can cause bleeding. So one of the mnemonics that people use is something called Shinesky, and I'm going to write down the components of Shinesky. So you have Shigella is the first. So this is a mnemonic. So Shinesky, I think this is the word. So I write Shinesky down in the chat. Okay? And
Okay.
so then I put Shigella. Okay? Then H is H influenza. Okay?
Mm-hmm.
So let me think about this. It's been a while since I wrote this out. I'm putting myself on the spot. So why don't I look this up? Well, I'm not gonna look it up. I'm gonna try with you guys. So do you guys know what I in Shinesky is?
No.
So
For
we
me,
have so N I'm not gonna lead you guys astray. I'm gonna make sure that I give you absolutely the best info I can. So Shinesky diarrhea mnemonic. You can look this up too, and you can follow along and get a visual understanding of what we're talking about. So this is one of those mnemonics. I don't own this mnemonic. This mnemonic's become so popular that it's okay to reference it. But in your first aid, you'll probably see Shinesky. And it's a great mnemonic that I'm having trouble finding on the web. But it's in your first aid book. And credit to them for creating the one that I think about when there's like diarrhea here, but I'm not going to spend too much time trying to find it because we have other fish to fry. But I'm going to find it in my first aid. Okay. So Campylobacter causes bloody diarrhea, right?
Mm-hmm. Yeah.
And so we can rule that out. And so I would very strongly, I'm going to send it, I'm going to even post this on the Facebook group Shinesky because it's such a good mnemonic. But I'm going to have to write it differently because it if you actually represent it as a picture of first aid, then it'll be a copyright infringement. But so what about Brucella?
No, I'm not gonna.
No, right?
No,
I'm not even
this.
familiar with Brucella as a cause of diarrhea very well. So
Yes.
I think that's a really rare cause of diarrhea, and so I'm ruling that out. So what are these two? What about Listeria monocytogenes?
No, for sure.
Right?
You know.
And do you know about
Yes.
Vibrio? What do you
Yes,
know about
because it's called
Vibrio?
water. Yeah.
Yeah. So Vibrio, one really interesting thing about Vibrio vulnificus is, do you know what kind of patient catches Vibrio more often than others?
Oh, no. But I know it's come from unwell cooked oysters and all of this stuff.
Perfect, exactly. So the oysters filter out the Vibrio, and then you eat the oyster.
Mm,
And so
yeah.
that's how you get Vibrio, is swimming in the
Also,
ocean.
yeah, watery
Yeah.
diarrhea. Yeah.
Yeah, watery diarrhea. Exactly. This is for sure watery. And so the people who actually get Vibrio more often than other people, Vibrio really likes iron. So that's a hint.
Mhm.
So it really likes iron to grow. And so what sort of patient has a lot of iron in their blood?
Hemochromatosis patient.
Exactly. And so hemochromatosis is otherwise known as bronze
Yeah.
diabetes.
Yes.
Because the iron accumulates in the pancreas, causing diabetes.
Yeah.
And
Yeah.
so that might be the cause of his hypertension, his hypercholesterol. But I'm just reaching, right? Because he was at a crawfish boil. We have oysters, we have seafood, and that's how you get Vibrio, is the ocean and oysters and seafood.
Okay.
And so what confidence do you have?
For sure, green.
Green. Okay. Yeah, I think you did very well in this one. That was great. So that's a good way to end the session, I think, with a perfect answer choice. And you really got the answer. I didn't. I just explained more about it because you had already kind of identified what you're going to say. But which part of Sudan do you come from?
I come from Jazeera, the middle.
Is that north or south?
Some in between, but it belongs to north more than south.
I know that's a slightly controversial, so I'm just curious because it's an interesting part of the world to think about. But thank you so much for attending with us, and I hope you got something out of this session. We this is exactly the pace that we go, and exactly the type of question answering that we do, and every week. And you're very welcome to attend without donating. And people come, they don't donate every week. When we do not require donations or anything like that, but it does help a lot. If you would like a private tutoring session with me, just tell Rowenda, and we can coordinate that as well. They're paid sessions; those cost money, but we have kind of a sliding scale, and we work with people on how much they want to pay at first for tutoring, so they can get an impression as to whether they like the tutoring sessions. And we don't use the game for tutoring sessions. We just go through the stuff that you want to go through, and then we can use the game, but we don't usually. And then because it's more fun to play the game. But I'll show you a few things about the game itself. If I wanted to move on to the next area, I could move to a tile and then hit this stage here. It tells us how many correct answers. We got 4 out of 5 correct. We killed 2 monsters, and then you go on to the next stage, and you have to traverse this stage to try to stay alive. So that's the object of the game, and we're going to have a multiplayer version coming out soon. If you go to your game reviews, you can go to game logs and look at this exact game. You can see how we got a question wrong in respiratory. You can look at the highlights. It'll remember those, the speed at which we answered, the date, the confidence, and whether we got it right or wrong. And so then we can go back and we'll actually have a summary game that will be multiplayer that you can play with other people, at which point you can choose the next thing faster than your friends and try to identify what happens next in this order. It's not portrayed this way. There's going to be arrows, and it's going to tell you that the next thing is a diagnosis or a treatment. And so that's going to be a fun way to one of the most arduous things about USMLE prep is reviewing questions you've already seen. But it's also the most useful thing to your score to keep reviewing things that you got wrong once and never getting them wrong again. And so that's what this software is intended to do. And just a reminder, we have Patreon and we have links to donate. And thank you, Sinaida. That's very nice. Appreciate it. And thanks for coming every week. It's really nice to see people who come regularly to these sessions coming every week, and so and to see new people choosing to join us. So I will also mention that we have a YouTube channel, and Rowenda will post a link to the YouTube channel or send it to you guys individually, so you can actually access this video and see it. And you'll see in the other videos, you know, people get things wrong, people get things right all the time. Do not be self-conscious, you know, kind of show up, you know, and just use it to remember what you get wrong. But I'll leave you guys. Thank you so much. I talk a lot this session. Thanks for putting up with me.
I have a question. Can I ask?
Yeah.
So like before the meeting, are you like have some kind of topics that you already tell people to study, or just like?
Oh, no, we randomly do a subject. And so what I do is, the reason we don't randomly do it, the reason we choose specific subjects is I have certain subjects that I teach better than others. And so as I'm doing my prep, I've taken notes on certain subjects and identified things that people get wrong, or I should say I get wrong when I'm studying for step 1 and step 2. Those are the subjects that I bring up at the beginning of class, just so we wait for everybody to show up. And so, you know, I choose really high yield subjects, really, really commonly misunderstood or hard to remember details. And I try to make them a little bit, you know, create devices to make them a little bit easier to remember. So
okay, I just want to say thank you so much for this. And I found this really, really great, and I give you like
to hear.
You have to go and study and all of this, and really thank you for this.
Absolutely.
And I want to thank Rwanda also.
Absolutely. Everybody thank Rwanda. She makes this possible also, because she tracks people down and tries to find people to come to the meeting and organizes a lot of the meetings. And so so definitely thank her. And I'll see you guys potentially, if we have enough people, we'll have another meeting this week, or we'll wait until next week, and we'll definitely have enough people then. So look out for the posts on Facebook, and I'll see you guys soon. See you guys.
Thank you, everyone.
Thank you.
Thank you.
Recording stop.